Carbon dioxide diffuses far more readily than oxygen due to its higher solubility. Even small partial pressures of carbon dioxide gradients, typically only 5 millimeters of mercury between tissue and blood, are sufficient for effective removal. This is why carbon dioxide retention usually reflects ventilatory failure rather than diffusion impairment, a key distinction when evaluating respiratory disorders. Carbon dioxide diffuses across the alveolar capillary membrane far more easily than oxygen due to its 20-time greater solubility. Even though the partial pressures gradient for carbon dioxide is relatively small, only about 5 millimeters of mercury separated, it it is still sufficient for rapid equilibration. Because of this property, CO2 retention is rarely due to a limitation in diffusion. It's almost always reflecting alveolar hypoventilation or severe ventilation perfusion mismatch, VQ mismatch, which is an important diagnostic distinction clinically. When tissue metabolism increases without a proportional increase in blood flow, carbon dioxide production will increase. So this is normal. It'll increase here. And this accumulation will reflect an imbalance between metabolic production and removal based off of circulation. Clinically, this is seen as in conditions like exercising muscle, sepsis, or even ischemic tissue, where elevated partial pressures of carbon dioxide act as potent local vasodilators to restore perfusion and enhance CO2 clearance. This slide emphasizes that the tissue PCO2 is a marker of the balance between metabolic activity and perfusion. If metabolism increases and blood flow does not, tissue hypercapnia, high levels of carbon dioxide, develop. Conversely, increased blood flow can normalize PCO2 even during high metabolic demand. Clinically, venous CO2 levels can provide insight into adequacy of tissue perfusion, particularly in states of shock. Next, we'll look at oxygen during exercise.